The following podcast is part of a certified educational activity titled How to Integrate Perioperative Immunotherapy into Multimodal Treatment Plans to Improve Outcomes in Resectable Non-Small Cell Lung Cancer. Access the entire activity and complete the post-test at peerview.com/GWF860. Downloadable slides and practice aids are also available.
Hi, everyone. Welcome. I'm so glad to see so many people in the room, and welcome to all the folks who are joining us online through the virtual access. It's a real pleasure to be talking to you today about how to integrate perioperative immunotherapy into multimodal treatment plans to improve outcomes for resectable non-small cell lung cancer. It's a real honor for me to share the stage here with someone who I consider to be a mentor and really sort of the epitome of what a thoracic surgeon ought to be, Dr. Al-Torki from Weill Cornell Medicine. I'm joining you here in person today. Happy to be here from traveling down from Montreal, Canada. I practice at the McGill University Health Center. So why are we here today? I think there's a lot of gaps in care for the patients we look after with stage 1 to 3 non-small cell lung cancer. And obviously with gaps, we have great opportunities for improvement. There's been a lot of activity in this area. It's kind of hard to keep up, especially when a lot of the stuff is presented at medical oncology conferences and maybe not being brought directly to you, the surgeons who bear most of the risk with your patients of all of this activity, because it does affect our patients in a very significant way. So we'll be trying to explore some of the latest advances in neoadjuvant immunotherapy. That'll be my section, and then Dr. Al-Torki will talk to us about recent progress in adjuvant immunotherapy. And then we'll try and go through a couple cases just to sort of illustrate some of the many issues that we encounter, and then we'll do a Q&A. All right, so what about neoadjuvant immunotherapy for resectable non-small cell lung cancer? I just want to put this case, which happens to be a patient that I've treated in the last few years, for consideration. She's a 67-year-old female. She has COPD, and she shows up to my office as an active smoker trying to quit. She has reasonable lung function with an FEV1 of 70%, a DLCO of 65%. She underwent a TTNA that was positive for adenocarcinoma. The PDL1 was 70%. We were doing reflex NGS on these, and it was negative for any actionable mutations. She underwent an EBUS, and you can see on the right of the screen a sort of sizable level 7 lymph node, which was positive for adenocarcinoma. The rest of the staging EBUS was negative, so it's really a clinical T1B and 2 single station non-bulky tumor. There's a GGO there that's negative on PET. So we just kind of took that into account and committed it to memory for when she would go to the OR. Patient wants surgery, and so I want you to think about how you would manage this patient. We'll come back to it for the cases at the end. So there are some arguments to choosing neoadjuvant immunotherapy. The thought that the tumor is in place, the immune microenvironment is available for interaction, which is necessary to develop immune memory and clonotype-specific cytotoxic T cells. And so the idea that the tumor may be acting as a vaccine is theoretically appealing. It's also been demonstrated in preclinical experiments. And there's great value of these trials for discovery, research, and the interpretation of the pathological response to tailor adjuvant treatment accordingly. It's also something that's become really part of the standard of care for numerous other disease sites. I think lung has been sort of slow to adopt, but I suspect that will come with time. One of the big challenges we have now is interpreting the specimen after. It's not our challenge, it's our friends, the pathologist's challenge. And there is a great paper here, which is a consensus statement that was put out a couple of years ago by the IASLC. And it's not really meant to be specific to immunotherapy-treated patients. The whole purpose of this consensus was to develop a way of looking at the pathological specimens that could be interpreted regardless of the type of preoperative therapy given. And the two main endpoints that have been looked at are pathological complete response, meaning no residual viable tumor cells in the tumor bed or lymph nodes, and major pathological response, which is considered to be less than 10% viable tumor cells. Just from a historical standpoint, pathological complete response rarely would occur in more than 5 to 7% max when you would look at the older clinical trials. And for reasons of practicality, one could not design a trial based on an endpoint that occurs so rarely. So major pathological response was really developed as a way to study neoadjuvant trials with an event rate that was a little bit more frequent. And again, historically there would be, with standard chemo, about 15% of patients would get a major pathological response. There are numerous trials in this space. These are just the phase 3 ongoing trials. Just for context, it's important to remember that CheckMate 816 is the only one that was pure neoadjuvant, whereas all the others that will be coming to you in the coming couple of years, I would think, are periadjuvant trials where patients received preoperative chemoimmunotherapy followed by adjuvant immunotherapy. So I'll go into some of the details of CheckMate 816 because this is the main data set that will inform our care for the coming period of time. 816 is a phase 3 trial originally designed to compare nivolumab and ipilimumab to platinum doublet, but as the data emerging from the Nadim trial came through, this trial was amended to compare nivolumab platinum doublet to platinum doublet alone, followed by surgery. The eligibility criteria include patients with stage 1B to 3A by AJCC 7. Just for context, again, that would correspond to patients with stage 2, 3A, and operable 3Bs, the T3N2s, in the current 8th edition. If patients had a known EGFR ALK mutation, which was required for the Asian jurisdictions, they were excluded. If it wasn't tested or not known, they could still go on trial, which is possibly the case for many of the European and North American patients. They had to be ECOG 0 to 1 and have a primary lung tumor tissue available for evaluation. There were two independent primary endpoints. One was event-free survival, which is patients not progressing to surgery or having any evidence of recurrence or death from any cause in the follow-up period. And the second independent primary endpoint was pathological complete CR. The trial was powered for overall survival, which was to be tested hierarchically if both independent primary endpoints were positive. If you look at the baseline characteristics, they are quite, I would say, representative of our usual operable lung cancer patient population. Some features of note are the half of patients who came from Asia, 2/3 of the patients who had stage 3 lung cancer, probably an overrepresentation of squamous cell carcinomas from what might be in most North American usual practice. But those are the only, I think, striking findings that might differ from your usual practice. In terms of the treatment summary, I think what's very compelling is that 98% of the patients in both arms went on to the first cycle of neoadjuvant treatment, and 94% completed all 3 cycles in the chemoimmunotherapy trial. That was numerically superior to the 85% who completed chemo. One of the concerns is obviously non-progression for surgery. That would be front of mind for the audience in front of me today, with approximately 16 to 17% of patients not making it to surgery. Half of those were not because of things like disease progression. There were patients declining surgery or having insufficient lung function to progress to surgery. Only 1% did not go due to some adverse event relating to the preoperative treatment, and 7% had disease progression. One might argue if your disease is progressing on one of our most active regimens, maybe you shouldn't be operating on these people at all, but that's obviously for discussion. Another interesting finding is the reduction in the time or the duration of surgery. It's almost over half an hour. I don't have many tools in the OR that can enable me to operate that much faster, so it's a kind of a compelling finding in my mind. The first primary endpoint, which was reported at the American Association of Cancer Research last year by Dr. Ford, is the 14-fold increase in pathological complete response, with nearly a quarter of the patients having no residual tumor, either in the primary tumor or the lymph node, dissected lymph nodes. So that is a very significant finding. When we look at the forest plot, looking at the, this is really exploratory. It's important to remember that this is a relatively small trial and these are small subgroups. So not to overinterpret them, but it is interesting that regardless of stage or histology, there seemed to be benefit in terms of the pathological response rate, as well as the PD-L1 level, with even the less than 1%ers deriving benefit from a PCR standpoint. think the other interesting thing, which is important to place into context if you go into the detail of the paper and look at the EFS by stage, is to see that regardless of stage, patients had high rates of PCR in the chemo-nivo group as compared to the chemo-alone group, which might lead one to believe that regardless of stage, there will eventually be a significant EFS benefit. Again, those groups are small in the 1Bs and 2s. One of the most impactful findings is that this whole treatment approach didn't really incur any significant adverse events as compared to the so-called control group of chemotherapy with no real signals of toxicity. And what I find most impressive is that the grade 3-4 rate for the surgery-related adverse events was 11% versus 15% in the Nivo chemo group. I don't know what you guys quote for your patients, but when I see a patient for stage 1 lung cancer undergoing a VATS-LOB, I quote them a 10% major complication rate. And so these are much more advanced patients. I think this is a very interesting finding. ctDNA clearance, this is maybe hope for the future that we may have better surrogate markers of response on the treatment trajectory of the patient. I think the main take home, again, small subsets here, is that ctDNA clearance is sort of a required step to achieve a pathological complete response, with no patients getting a complete response who did not clear the ctDNA, but in those who did, there was 46%. So an interesting blood-based marker of what's happening in the tissue. Surgical outcomes, again, interesting. It's most of the effect seems to be in the 3A patients who presumably have more bulk of disease and more challenging lesions to resect, but we have numerically more patients being able to complete the operation by a minimally invasive approach. Half as many conversions. I want to remind you that this study was run in 150 centers around the world, some academic, some community, so it's really a representation of what the thoracic surgical community can do, and may not be comparable to a lot of the prior data, phase 2 data, which was done in high volume academic centers. And again, in the 3A cohort, there seem to be fewer pneumonectomies. We all appreciate the risk of pneumonectomy from a perspective of death from non-oncologic cardiopulmonary death. And so if we can reduce that, I think this is an impactful outcome. In terms of surgery-related complications, there was, again, no signal of significant risk for the chemo-nivo treated patients. The pain probably related to the fewer number of patients who needed open surgery in the chemo-nivo treated patients. It's not here, but if you look at 90-day mortality, and you can just look at it in the paper, it's 2.8% after this chemo-nivolumab. That's, again, pretty good. If you look at STS database, 90-day mortalities for lung resection, they're quite a bit higher than that. Length of stay, so we have 10 days in both cohorts, but we know that how long you keep a patient in the hospital is a cultural phenomenon driven more by dogma and habits than it is by necessarily science. But in North America, you have about a 2-day median reduction in length of stay. In Europe, it's a little more than 3 days, and 2 days in Asia. We all know how challenging it is to demonstrate a reduction in length of stay through ERAS and all the efforts we do. The fact that the treated group in areas where there may be more consistent habits in terms of discharge, again, I think is quite significant. Here's the meat of the paper. EFS is significantly improved in the chemo-nivo treated group, nearly 20% benefit at 2 years, and almost a year of extra life without recurrence. And so that's an impactful finding. When we looked at subgroup analysis, again, interpreting these things with caution, generally most subgroups derived some benefit, though statistically it's hard to tell if there is a significant benefit in some of the subgroups. I think questions that will emerge are the PD-L1 less than 1% patients and the stage 1B2 patients. We may need more time to figure that one out, and perhaps larger numbers. This is really interesting. If you can tell your patient that they had a PCR after resection, you can tell them that they're pretty close to being cured. There's a very significant difference here between the PCR and non-PCR patients. And for me, the most important slide, a 12% benefit in in overall survival at 2 years. Remembering, and then, the p-value is 0.79. Once you've chewed up all the alpha for the two initial primary endpoints, and with the hierarchical testing, the threshold was 0.33. So it's not statistically positive, but for me, this is clinically extremely positive, and it embeds the accepted approximately 5% benefit of having given chemo. Many of the adjuvant patients will not make it to chemo. So again, I think this is a very powerful finding. This is an approved regimen here. I wish it could be approved in Canada a little quicker, but for the time being it's not, and we'll see what happens with the rest of the world. And so in terms of my conclusions, I think patients with resectable non-small cell lung cancer, this regimen of nivolumab and chemotherapy preoperatively prolongs the FS. To me, this is an important endpoint. It induces high rates of PCR, again, something I think is quite important. And this is all without having really increased risks for our patients. I think I've already said this stuff, and I'd like to hand over to the boss here, Dr. Al-Torki.
Thank you, and it's great to be here. It's great to see you all here, packed in together like that. The last 2 years have really been banner years for patients with lung cancer. Who would have thought that? We had the ADORA trial in September of 2020. We had Empower 010 in October of 2021, and the CheckMate trial and Pearl trial. So it was an amazing accomplishment, as we know. Now, I'm here to talk to you about the adjuvant therapy trials. And we'll start with this case. 55-year-old Asian American man with extensive smoking history, comes in with hemoptysis, has a right upper lobe mass, negative brain MRI, PET otherwise negative, had a right upper lobectomy with mediastinal node dissection done, R0, and the PD-L1 is 70%, and was not EGFR or ALK rearranged, and had a KRAS mutation, pretty unusual for an Asian American man, but only one positive lymph node. And he got cisplatin pemetrexed 4 cycles at that final stage, stage 2B. So there are 4 randomized trials of adjuvant immunotherapy in non-small cell lung cancer. The ANVIL trial, the Empower 010 with each adjuvant atezo, the NCI Canada trial of BR31 of adjuvant durvalumab, and the Pearl trial, which is another global trial with adjuvant pembrolizumab. Both the atezo trial and the ANVIL trial will probably report late this year. The other 2 have already reported. So the first one to get out of the gate was Empower 010, and that basically took patients who had completely resected stage 1B to 3A non-small cell lung cancer that had an R0 resection, and they were registered at that point, and then went on to receive up to 4 cycles of cisplatin-based chemotherapy, and then randomized 1-to-1 to receive 1 year of adjuvant atezo or best supportive care, which is essentially observation. And the primary endpoint, which was disease-free survival, was tested hierarchically in the following manner. So it was first tested in patients who had stage 2 to 3A that were PD-L1 positive, and if positive in that cohort, was tested in patients with in all the randomized stage 2 to 3A patients, and if positive, it was tested in the IITT population. And if then positive, overall survival was tested in the entire population of patients. A key secondary endpoint was disease-free survival in patients expressing PD-L1 in 50% or more of the tumor cells. The study was reported first in June of 2020 at the ASCO meeting. And this table basically shows that the baseline characteristics are fairly well balanced in terms of histology. More than 50% were non-squamous histology. Well balanced in terms of the proportion of patients expressing PD-L1 in their tumors. I want you to make a mental note of the stage distribution here. We will come to that when we discuss keynote. So roughly about 11 or to 12% had stage 1B. 41 or 42% had stage 3, and roughly about 45 or 47% had stage 2 disease. Now, you can say that these patients had the Cadillac treatment. What is the Cadillac treatment? They had a lobectomy, and for the most part, 77% had a lobectomy too, 80% had a mediastinal node dissection, and all of them had cisplatin-based chemotherapy, the majority of whom had 4 cycles of the prescribed treatment. Only 15% had a pneumonectomy, and less had a bilobectomy. Okay, so there was one interim analysis for DFS, and that was done. In the first interim analysis, there was a superior disease-free survival in the target population, which is stage 2 to 3A, expressing PD-L1 in 1% or more of the tumor cells. The median survival was not reached in the atezo arm and was 35 months in the best supportive care arm. The hazard ratio was 0.66, and the p-value was 0.004. As you can see here, there's almost a 12-point separation at 3 years in DFS. Then it was tested in all the stage 2 to 3A population, and again, there was a significant difference in both the median survival as well as in the survival at 2 and 3 years, and the hazard ratio was 0.79 with a p-value of 0.02. Now, they went on to do DFS in the ITT population, and although it was numerically higher in the atezo arm, it did not cross the statistical significance boundary. So this will have to wait until the final interim analysis, which I'm thinking maybe probably sometime next year. This is the forest plot, and again, as Jonathan said, an exploratory analysis looking for the impact of various clinical and pathological variables on DFS. And as you can see, to the left means atezo is better, to the right means best supportive care is better, and by and large, atezo is better in almost all the key groups. And again, what's important here is that one does not draw a lot of conclusions, it just gives you a bird's eye view of what to expect. The important point, this is the forest analysis, I'm sorry, the previous one was in the patients expressing PD-L1 in more than 1% of the tumor cells. This is in all the stage 2 to 3A patients. So you can see one of the questions that was raised almost before the presenter, Dr. Wakely, left the podium is the impact of PD-L1 expression on outcome. And it was largely driven by those that have PD-L1 expression 50% or more with a hazard ratio of 0.43. Think about that for a second. That is a 67% reduction in the hazard rate of death or recurrence disease. That's an amazing finding. I still, every time I look at this, I'm very impressed. And the ones that had more than 1% also had a favorable hazard ratio. Those that had less than 1% did not get any benefit. Now, approvals have generally been in the United States for anybody expressing PD-L1 more than, well, not anyone, 2 and 3A expressing PD-L1 in 1% or more. I think in Germany, and if I'm not mistaken, and in Switzerland, maybe you can correct me if I'm wrong, it's approved only in the 50% cohort, with good reason, I would say. And this is the sort of a graphic representation of DFS across all levels of PD-L1 expression. And see, this is the more than 1%, which is statistically significant. Here, the hazard ratio approach, is okay. It's 0.8, I think, but it does cross unity. But there is, the curves are not exactly overlapping, and this is the effect in the PD-L1. Almost a 20-point difference in survival in that cohort. And then when you exclude those patients that had EGFR mutations or ALK alterations, the curves look a lot better, numerically better, but still the hazard ratio crosses unity. So this is something we presented at the World Congress about a year ago, I think. The impact of treatment characteristics on DFS in those patients expressing PD-L1 more than 1%, and basically across pathological stages, across node-positive disease, surgical treatment, and type of chemotherapy, everything seemed to favor atezo. The questions that we were asked, and will probably be asked in the discussion, is what about the pneumonectomy group, and what about those guys that got cis-gem rather than any of the other combination therapy? And it's important, again, to point out that these subgroups are not powered to answer that particular question. So by and large, this is hypothesis-generating data. Now, what about circulating tumor DNA? Well, the investigators did a really good job at collecting plasma for circulating tumor DNA, and it turns out that circulating tumor DNA was strongly prognostic. So if you look here, patients who had ctDNA negativity, clearance of ctDNA in the plasma, in that group, atezo did significantly better than those that had best supportive care. And of those that had residual ctDNA in the plasma, atezo was still better than those that got best supportive care, which tells me two things. One is atezo in overall is better than best supportive care, and two is ctDNA, of course, is a strong prognostic indicator. But before we get on our high horse and start that ctDNA is just such an amazing thing, if you look at this, if you get chemotherapy and atezo and clear your DNA, you still have a 40% chance of recurrence of disease beyond 3 years. So that's important, and I think there's a lot of work that still remains to be done. Well, what about the adverse events? So the grade 3-4 adverse events were 20%. Question was asked was, okay, well, how do you recommend treatment with something that has a 20% grade 3-4 adverse events? And the answer is easy. You balance that against the risk of recurrence and the cohort that you're treating. If you're treating somebody with stage 3A, maybe the balance favors atezo. His AE that led to discontinuation of the drug was 18%. So that's important in any immunotherapy. I mean, remember, we give those arbitrarily for 1 year, sometimes for more than 1 year, and nobody really knows how long you should give them for. So, most patients would stop the drug, in my experience, after, not in this trial, but in our own personal data, less than 1 year. And I have 2 minutes. Okay, so let's jump over this. Okay, so the overall survival data were not, still have not matured, and probably will mature later this year. And as I said, the FDA approved the atezo in the population that I just described in October of 2021. So in February, I think, of this year, or March of this year, Keynote 091 was presented at ESMO, and this took patients, again, with completely resected stage 1B to 3A non-small cell lung cancer, and then randomized them to, made a recommendation for chemotherapy, strongly recommended in patients with stage 2 to 3A, and were randomized to adjuvant pembro for 1 year, or, I can't see from here, placebo. And there were two co-primary endpoints. One was DFS in the overall population, and the second co-primary endpoint was DFS in patients expressing PD-L1 in more than 50% of their tumor cells. And that is going to prove very interesting in the data, as we can see. I wanted you to then reach into your memory bank and see the distribution of cases here. So about 15% had stage 1B, but the proportion of patients in stage 3A was much lower here than it is in the Empower 010. So this was mainly weighted towards stage 2 disease. And 14% did not receive adjuvant chemotherapy. Probably most of these are going to be stage 1B, so for all intents and purposes, one can skip over that particular point. There was a significant difference in DFS in the overall population, no doubt about it. The hazard ratio was 0.76, the p-value was 0.001, so again confirming the value of adjuvant immunotherapy in this setting. And here is the puzzlement. For those that expressed PD-L1 in 50% or more of the tumor cells that has such an astounding improvement in survival in Empower 010. This was essentially overlapping with the 2-year survival of 70 and 71%. I don't know what the explanation of that is. It's clearly not significant. This is just an exploratory forest plot of all the various groups, and by and large, most of these favor adjuvant pembro. Now, there were some differences here. So grade 3 to 5 events were 34% here, which is a little higher than after adjuvant atezo, but those that led to discontinuation of the drug was about the same, 19% versus 18%. So in conclusion, the use of immunotherapy in the perioperative management of resectable lung cancer is a major advance. This is the question that will trouble all of us as we go forward, which is when to do adjuvant, when to do neoadjuvant, and of course we all need better biomarkers to try and figure this one out. Thank you.
All right, thank you, Dr. Al-Torki. I think that basically is a rapid overview of the available data for at least the phase 3 data that we have, and maybe we'll just go through back to our original case, this 6 to 7-year-old lady with acceptable lung function for lung resection with the stage 3A lesion. I'm going to ask you guys again, and will be a number of polling questions, so yeah, thanks. Please try and answer quickly so we can move on to the next and get to more discussion. So before we ask you guys, what would you do, Dr. Al-Torki, for this patient? Try not to taint the group too much.
I was going to eat my cookie. That's what I was going to do. No, I agree with the consensus. Give her neoadjuvant immunotherapy plus chemo and proceed on to surgery. I'm a little worried that she had bulky subcarinal nodal disease, though.
Fair enough, and I think that's one of the big debates is what is bulky, how do we make that decision, and that's a moving target. Okay, so this is actually what happened. We treated her with neoadjuvant chemo IO. I'm pretty sure she received IO because she developed hypothyroidism on induction. This was a blinded trial, which is one of the big challenges we had in the last few years is managing patients who might have had placebo or might have had treatment. And on the below series is the post-induction scan. So you can see that the primary lesion in the SUPSEG reduced in size. The GGO also contracted a little bit, and there's some response in the subcarinal lymph node. So the reason why I think it's important to think about this is that this is what we found. This is a lady, we kind of made up the case. She actually had less good lung function than what we showed you. She had pretty severe emphysema. And this is all the lung that you're taking out only for this tiny little lesion up at the apex in the SUPSEG. And when we looked microscopically, she had a path-complete response in that primary tumor. And interestingly, the middle lobe wedge had residual carcinoma. It looked like a when we did NGS, compared it to the original lesion. It was a different primary, but it didn't respond. And that level 7 was complete response. So there was theoretically an opportunity to de-escalate the operation in this patient. Do you have any thoughts on that, Dr. Al-Torki?
Yeah, that it's very hard to predict that. I mean, you know, it could have easily gone the other way, and you would have had residual disease in the
right.
But you know, like again, you produced a spectacular result, so I'm not going to argue with success.
Well, it wasn't me; it was the med-onc who gave the treatment. I guess I just did the operation.
Yeah.
But we will face these situations increasingly, and these, I think, questions will emerge.
I mean,
frozen section help?
So this is a question from Dr. Abbas asking if frozen section would help. And I'll tell you that in my practice, as I've started to believe in this more, I have tailored my practice enormously. And whereas I used to get annoyed about asking for frozen sections because it would slow me down, I ask for it a lot now. And I think it's quite a valuable adjunct. The pathologists do give us a hard time because it's hard for them, and they see a lot of inflammatory cells, small blue cells. They don't know necessarily what to make of it, but I do think it's quite helpful.
I would like to be a contrarian here.
Good.
So the data are that if you give chemoimmunotherapy and then do a lobectomy, you get the results that you got.
Yeah.
So many of you know that I'm a PI on a limited resection, so I have nothing against limited resection, but we have to test that because
yes.
I think, although it may be success, and you know, with immunotherapy, it's really hard to tell what is residual cancer and what is not, and it may be hard for the radiologist, for the pathologist as well.
Yeah, I think it's an important caveat. Well, I see your question. We'll just go to the second case, and then we'll take more questions. So this is your patient, Dr. Alter.
Yes. So this is the Asian patient that had a KRAS mutation, had a complete resection.
So I think there's so much to talk about. I saw one hand go up, so maybe we can get... please speak into the microphone just so that our virtual audience can hear you.
So, Nasser, in the setting of multifocal disease, like the first case, I mean, what do you think about the segmentectomy in the lower lobe and then the wedge in the upper lobe, as opposed to doing the whole lobe? I mean,
I think that we make clinical judgments every day for each individual patient, and faced with a patient who has borderline pulmonary functions, maybe I'd consider it. But I think it's also important to understand or internalize what the results of the trial were. And, I have no problem with doing a segment and a wedge in individual cases as the clinical situation demands.
Yeah, I think it's important to make a difference between the data we have and the practice we should adopt, and how we need to get engaged as a surgical community into developing the science on this work. They're kind of two different questions. But none of these trials prospectively ask surgeons to evaluate the patient at presentation, after induction, and comparing all that to what was actually done. And that's super important data, right? Because our judgment may change as time goes. Someone could bring the microphone over here. In the meantime, I'll take another one of the virtual questions. So one of the questions comes up about pseudoprogression. Does that happen? Dr. Altorki, have you...
I feel very strongly that it doesn't. And I think your data are pretty conclusive that it doesn't. Disease progression occurs at similar proportions both in the chemotherapy and the immunotherapy arm. We forget that those patients that we give cytotoxic therapy to progress during therapy. I mean, that's just the way the disease is, and to ascribe it to immunotherapy, to me, doesn't make any sense.
Yeah, I agree. I think anecdotally, I might have seen it more in patients who had pure immunotherapy regimens, sort of nivolumab, ipilimumab, or just an anti-PD-1. And even then, I'm not totally convinced of the phenomenon. Obviously, you might see it on PET. If you do PET restaging, you may see more avidity than you saw before, because these are heavily infiltrated lesions with cells that eat glucose for a living. So that may occur. What are your thoughts on...
Before you ask me about my thoughts about this, I want to know what happened to the Ipi-Nivo arm.
So it's an excellent question, and I haven't seen the data yet, but I do expect it to be out at some point. There is a plan to bring that to be shared. And I think my expectation is that we'll see something of interest, but anecdotally, again, these were as easy as the chemoimmunotherapy patients were to manage preoperatively. I did encounter more issues, again, anecdotally, with immune-related adverse events that were problematic in the Ipi-Nivo patients.
Did it prevent surgery?
Not in my hands, but we had more delays. So we had more patients who had to go on steroid tapers, and then I didn't like to operate on patients who are on high-dose steroids, so I'd wait a little bit more. And I see Dr. Vader here, who is an eminent personality in the neoadjuvant space. Could we bring him the mic, please?
Thank you both for excellent presentation. The only study we have in a randomized fashion looking at the question neoadjuvant versus adjuvant in chemotherapy showed no difference. So what do you expect now using IO as adjuvant or neoadjuvant? Which one do you personally favor, even in the lack of enough data?
Fair enough. I would like to have Dr. Altorki answer these things first.
Well, so that is actually an interesting question. I think for patients with stage 3A, clinical stage 3A, I think most people in the room would be would have a consensus that these guys need neoadjuvant therapy. For patients with stage 1B and 2, I think if you dive into the supplement of the New England Journal, you will see that the survival is not much different for stage 1B and 2. Now, again, it's a small trial. Maybe the numbers were not powered for that. In my practice right now, for stage 1B and 2 that are otherwise, I feel I can get a good R0 resection, the high probability of an R0 resection, and that are PD-L1 expressing, I think that it's perfectly okay to operate on them and give them adjuvant therapy. If I thought that they were PD-L1 negative, they're not so sure about the data with the neoadjuvant, but I would be more inclined to give them neoadjuvant combinations. And if I thought that they were that I would be unlikely to get an R0 resection, I would give them neoadjuvant. I don't know what everybody else thinks. So, what do you do, Walter?
The early stages is not yet approved that we do neoadjuvant treatment, except for the stage 3A, as is mentioned. The advantage of neoadjuvant treatment is that we see a response in the specimen, and we have seen some really nice responses. And if you have a complete pathologic response, you are maybe done. But if you have still residual disease, you might go on with further treatment. So I think the direction might go in this way. So this is why I favor neoadjuvant in many situations, at least in the more higher tumor stages or tumor sizes.
Well, it's very helpful to have that because that would be my practice as well. I think what we have to remember is even in the stage 1Bs and 2s, the most common cause of death in these patients is metastatic disease afterwards. And although the EFS benefit in the stage 2s is not dramatic, it's a 2-year endpoint, the events may take longer to accumulate, and you've given 85% of those patients that extra 4 or 5% survival benefit by giving them chemo. Now, although none of my patients have complications, I know that the data indicates at least a third to a half of patients don't make it to their indicated adjuvant therapy.
But it's such a perfect question for a trial.
It is. You're absolutely right.
I'm also an advocate of neoadjuvant therapy, but I think it's important that that we all know that it's not mandatory in those stages. 100%. And if you look at the DFS and the EFS in the two trials, they're essentially the same. The delta is the same.
That's fair.
Yeah.
That's fair. But I think, again, for the people in the room, we're the surgeons. Historically, we've been the barrier to these trials accruing, and these patients are in our hands. So if we were to do an important trial, which I think Dr. Al-Turki is pointing out is a very important trial, it involves us being participatory to the exercise. We have another question here from the audience.
There's one here, then there.
Okay.
I enjoyed the presentations. Thank you. Seeing that immunotherapy is associated with maybe a 1 to 3% risk of pneumonitis, does that taint your enthusiasm to give radiation therapy, either pre-op or post-op? If you give immunotherapy, are you willing to give immunotherapy and radiation simultaneously?
So I think, Dr. Daltoga, you have the most experience here of combining immunotherapy and radiation.
Yeah, but we published a trial combining immunotherapy with radiation, but 8 gray times 3, which is not a usual dose. It's a total of 24 gray, which is the biological equivalent of 43 gray, which is much less than what you would give those people. So I think radiation in the early stage disease has taken a big hit with the adjuvant, I forget the name of the trial. What was it called?
LungArt.
The LungArt trial that showed no difference. So we're not giving that anymore. And I think very few of us are going to combine chemotherapy and radiation as an induction regimen with immunotherapy for exactly the reasons you identified. And I think the concern about the impact of interstitial pneumonitis or immune-related pneumonitis in the induction regimen or even in the adjuvant regimen have proven to be not as big as we thought they would be, so that's good. In patients with stage 4 disease, where you keep those guys on immunotherapy for an extended period of time, then it becomes a problem.
Mm-hmm. I agree. For us, even before these regimens came on, we've really reduced the amount of preoperative radiation that we use, not seeing much benefit, but we may see something different as a sensitizer to immunotherapy as time goes on. I
think we have a question
Sure,
there,
yeah,
and then
please.
A question in the back.
Dr. Broderick.
A bit more of a comment than a question. And Dr. Al-Turki, you sort of skived this issue a little bit when you try to compare, and I'm seeing a lot of people comparing outcomes in Empower 010 versus CheckMate 816. And as a community, we need to be really careful about these cross-trial comparisons because they're not the same patient populations. Right. Taking people who had a pathologic specimen that may have shown occult nodal disease and enrolled in Empower 010 versus someone who preoperatively we identified nodal disease or 1B disease and put on a neoadjuvant trial. So the deltas are the same, but we can't take outcomes from Empower 010 and say, well, let's just give them adjuvant.
On that issue, how would you counsel a patient who's had a PCR in terms of bringing that patient to tumor board and advocating for continued IO? I've heard people now that in the U.S. you have access to both regimens. You may continue a TZO.
We just spend more money. That's all.
Well, that's certainly not going to happen in Canada, but I wonder how you approach those situations.
Well, I mean, I have a very peculiar view on this. Which is, I think that the response to immunotherapy is immediate and very swift. And in the trial that we did, if somebody had a PCR and they were reluctant to get adjuvant durva, that's fine.
Right.
We didn't give it to them.
Fair enough.
Yeah.
Okay, we have time for a couple more questions. Yep, please, at the back there.
Yeah, so back to the radiation question. So for 3A disease, is the CheckMate regimen going to replace the chemoradiation treatment prior to? And when is that going to be reflected in the NCCN guidelines?
Well, I'd encourage you all to attend a session tomorrow. It's unclear yet whether it will be Dr. Stiles or Dr. Bott presenting due to some COVID issues. But it's essentially a presentation of the AATS Early Lung Cancer Work Group. And you'll see some of the consensus statements that emanated from that work. In my practice, there's it's hard to find scenarios where I think preoperative radiation is of any help. I think the exceptional circumstances of a patient with intractable pain, chest wall invasion, or something like that, where you might want to get some multimodality therapy in it. But even then, I would probably treat them with chemoimmunotherapy.
And the PCR rate with chemoradiation is 25%, 20 to 25%. So it's hard to argue, in its favor. Because I think it brings a series of new challenges to the management of the patients, especially if you're going to give them adjuvant IO after that.
Last question, because we're almost up at time here. Dr. Al-Turki, do you restage after neoadjuvant treatment?
No. I mean, I restage for systemic disease, but I don't restage for, I think the decision is made. The die is cast, as they say.
I agree. I think it's important. The last thing I'll remind folks for CheckMate 816 is that these were patients who had to be sort of considered operable at presentation. So while the regimen does provide some hope that we may be able to downstage patients who present as unresectable, the practice really should reflect the trial, which is to administer the treatment to patients who present with operable disease and operable physiology so that we continue to have these good outcomes.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GWF860. This activity is supported through educational grants from Bristol Myers Squibb, Genentech, a member of the Roche Group, and Merck & Company Incorporated.